Good afternoon, everybody, and welcome. Welcome to our wonderful room here in our symposium, the Transdiagnostic Approach, Treating Symptoms Across Mood and Thought Disorders. I'm Roger McIntyre, psychiatrist, professor of psychiatry and pharmacology at University of Toronto. I've been asked to be the moderator or chair, whatever the monikers we're using for this afternoon's proceedings. And I suppose I should also say welcome to this beautiful city during Fashion Week and the ECNP broadly. Now, we have an ambitious schedule, and I'm going to keep my remarks fairly pithy and brief at the start, but I might say somewhat extemporaneously here that I think this is one of the most important issues in psychiatry today, not only for clinicians, but also for academicians involved in translational research that endeavors to identify the underlying pathogenesis of brain-based disorders, but also in the clinical ecosystem as we approach our patients with the aim to have timely detection and diagnosis and then make treatment considerations. And over the years, we've had pendulums swinging in psychiatry with respect to the categorization and the dimensionalization of psychopathology, with a noble objective to find a way to reliably and timely diagnose mental disorders and find a common language, that be the lingua franca. But I also think it's timely in the sense that we are developing so many new therapeutics in the field, and as clinicians, we know that many of our treatments do not respect the categories of ICD or DSM. Our treatments have application beyond their on-label indication. And as it relates to treatments we currently have that are fit for purpose, we're now seeing expanding indications for some of these treatments, and a rationale to expand indications also guided by this recognition of transdiagnostics, common neurobiology, and perhaps therapeutics that can be applied across many different disorders. So something that's going to be very academically interesting, but also clinically relevant. Just showed you there my disclosures. That was rather wiki. We'll go back, and there's my disclosures of organizations that support my endeavors as a psychiatrist, as an academic. But I think this summarizes very succinctly the outline. We're going to start off with transdiagnostics, and we're going to talk about how this should be conceptualized. And we have, in fact, Dr. Paolo Fusar-Pauly from King's College is going to provide us that set point in our conversation. Then we're going to look under the hood. We're going to look under the hood, as we say, and we're going to talk about dopamine partial agonists, transdiagnostic drugs. I was asked by the sponsor, Gideon Richter, by the way, we thank them for their sponsorship, to make the case very clear, unequivocal, and make it certainly unambiguous that cariprazine is approved here in Europe for schizophrenia, but other parts of the world, like USA, for adjunct MDD and bipolar. So we just want to make sure we stay within the guardrails of at least understanding. Dr. Andrea Bartolomis is going to talk about that topic about dopamine partial agonism. I think the theme that will emanate is a point of commonality in neurobiology provides the basis for a common treatment across multiple disorders that targets key neurobiological substrates common to these conditions. And then we're going to get into what this means in clinical practice. So without further ado, let's get started. I'm going to invite, I think Dr. Paolo is going to come up first to give us the first presentation on the topic of transdiagnostic approaches, treatment symptoms across mood and thought disorders. I'll be sitting over here taking some notes and contemplating and marinating, and I'll have a brief presentation at the end where I'm going to try and bring this together in a way that I hope is not just a synthesis, but provides for you all takeaway messages. For Dr. Paolo Fusar-Pauly, come up and join me if you will. And you're going to start us off with the transdiagnostic approach, treating symptoms across mood and thought disorders. So welcome.
Good afternoon. It's a great pleasure to be here, and thanks to the organizers and the sponsors. Buon pomeriggio, benvenuti a Milano. Fa piacere essere qua. I was asked to give a gentle introduction about diagnostics and transdiagnostic approaches in psychiatry, and we try to provide a balanced overview of pros and cons across the two approaches. Those are my disclosures. So let's start from the standard diagnostic approach. Where is it coming from? Where are our standard diagnostic approach, where is it coming from? So the birth of the standard diagnostic approach we are currently using dates back to the 19th century, where eminent psychiatrists like Kraepelin or Pinel, they started kind of proposing the initial classifications for mental disorders, such distinction between manic depressive, insanity, and paranoia or psychosis. That's one of the first attempts by Kraepelin. And interestingly enough, these psychiatrists at that time, they were living with their patients in the asylum. They were spending most of their life with their patients, and therefore they were optimally positioned to assess, detect, and also follow up the trajectories of the presenting features and symptoms. And therefore, because they were clever clinicians and observers, they've been able to use their human classification skills to imagine different phenotypes based on symptomatology. And that's basically the base of our current diagnostic system, which is currently reflected by the two international manuals, ICD-11 and DSM-5. And here we see already one of the problems we have in psychiatry. We have two competing diagnostic systems that have improved over the most recent years, but still they do not always use the same language, the same terminology, and sometimes they are conflicting, even within the standard diagnostic approach. Then what is the pros? What are the benefits of our current diagnosis? I think that the benefits are illustrated by this historical painting you are all familiar with. It's Pinel trying to help a woman, trying to free her and try to treat her, diagnose her with medical knowledge for the first time. So the diagnostic system has allowed psychiatry to become part of medicine. And I think this is a very basic but also important point which we need to accept. For psychiatry to remain within medicine, to remain a clinical practice, we will need a diagnostic system. We somehow would need a diagnostic system. And this is not a trivial statement. You may have read about this recent trend about several papers claiming to be adiagnostic, suggesting that psychiatry should abandon diagnosis at all. Do we really want psychiatry to be just a research enterprise, an academic enterprise with no real-world impact? Then in that case we can, well, disregard the diagnostic issues at all. So the second positive aspect of the current diagnostic system is if we stick to the operationalizations and definitions, for example, provided by ICD-10, 11 or DSM-5, they somehow have a good reliability. So level of agreement between raters is not bad, particularly for some of these diagnoses. If you look at the field test trial for ICD-11, the agreement, intra-class CAP agreement, is quite high for schizophrenia, for bipolar I disorder, for recurrent depressive disorder, and so forth, is about 0.8. That's not bad. We can agree on a certain endophenotype, but what is the problem? And that's basically the issue the problem why we are here. The current diagnostic categories, they lack clinical validity, and this has been raised by several recent editorials and forums and scientific papers. For example, one of these, published in World Psychiatry, raised the question, how are mental health professionals using the ICD and DSM? And this is a question for you. How are you using these diagnostic categories? And the answer was that clinicians are using ICD and DSM largely for admin purposes, for reporting purposes, not certainly to guide their treatment or to inform the prognostication or to talk with their patient and to explain them what they are going through. This is the first problem, lack of validity, clinical validity. The second problem is huge comorbidities. When it comes to formulate a primary versus a secondary diagnosis, it's very difficult. It's very difficult, and then we all struggle, and then we all observe a huge portion of overlap between primary and secondary mental disorders, and comorbidity is a rule in our clinical practice. And the third issue is that the diagnostic system, as it is conceived now, is a kind of a crystallized system which does not account for the recent discoveries regarding, for example, the clinical staging models. According to the clinical staging models, we know that several mental disorders, such as psychosis or mood disorders, they fluctuate from a very early phase, clinical high-risk phase, prodromal phase, to a first episode phase, relapsing phase, and chronic phase. And the symptomatology and presenting features of these disorders across the different phases change and is very different, and the current diagnostic system do not incorporate this notion. Having said so, let's look at what the transdiagnostic approach is offering and in terms of benefits and limitation. To explain what the transdiagnostic approach is, I just use a publication appeared this week in JAMA Psychiatry by Professor Leucht, which is plotting in this spider web the clinical trajectory of a young boy who was at risk of developing psychosis and then who developed the disorder. And you see the different psychopathological dimensions plotted in the spider web: psychosis, but also bipolar or depressive disorders, anxiety disorder, OCD, eating disorders, and so forth. And then from the inner to the outside, we have the clinical staging model. So stage 0, asymptomatic, stage 1A and 1B, it's the prodromal clinical high risk period, attenuated symptoms, some disability, but still not the onset of the frank psychotic disorder. And then in stage 2, we have the first onset of psychosis, in this case, stage 3, early relapsing, and stage 4, chronic stage. And as you can see from this illustration, in the very early stages, different psychopathological dimensions, they overlap, they are blurred. It's very difficult to distinguish when we assess, for example, someone who's young, who's at risk for developing psychosis, whether they will actually develop the disorder, or maybe they will go on to develop bipolar or other mental disorders, because they will have a little bit of different problems. And particularly, if you look at adolescents or young persons, they would have typically overlapping and blurred psychopathology. But with a follow-up of time, and then you will see that these individuals will go on to intensify the psychosis-like features and to develop eventually psychosis, but together with some partial overlap with other dimensions like bipolar disorders and depressive disorders. Therefore, the transdiagnostic model, as exemplified in this visual case, can account for comorbid dimensions, in this case psychosis and mood disorders, as well as for the clinical staging model. And this is a huge advantage for the second advantage of the transdiagnostic model is that we think it's closer to the underlying neurobiology. So this is another recent paper published on Nature Medicine, analyzing with neuroscientific methods, neuroimaging, potential biotypes underlying the presenting symptomatology. And the paper identified 3 different biotypes, different patterns of correlation between different brain areas, and trying to map it onto existing diagnostic category. And as you can see, the red portion is highlighting how well the biotype is mapping onto existing category, and the matching is only partial. So it means that there is a huge overlap in terms of underlying biotypes across existing diagnostic categories. And this obviously it's paving the way to explain why we have treatments which can operate and work across different diagnostic categories, as the next speakers will be elaborating on. For example, the third major advancement of and benefit of transdiagnostic approach is to allow testing innovative treatments across multiple conditions, as I was saying. For example, if you look at dopaminergic alterations, and particularly presynaptic dopamine synthesis, which is represented in this axis, the level of dopamine synthesis in the striatum, and the level of positive psychotic symptom, you see that there is a correlation which is significant not just in schizophrenia and psychosis, as we all know, but also in bipolar. And this has been established and demonstrated with neurochemical imaging, with PET, by my colleagues Samir Jawhar and Oliver House at King's College London. And the next speaker, Professor De Bartolomei, will explain us how we can leverage this transdiagnostic finding to inform new treatments. So this is all good, but I also promised a kind of a balanced approach. What are the limits of the transdiagnostic approach? Well, first, what is actually transdiagnostic approach? What do we mean by transdiagnostic? I looked at Collins Dictionary and says, no result for transdiagnostic in the English dictionary. Cambridge Dictionary, same. Online Medical Dictionary, again. It's a new word. It's a trendy word. It's a trendy approach. Again, we need to be cautious and we need to filter by evidence first. So we looked at the evidence and we interrogated the existing literature. We conducted a systematic review of all papers which acknowledge being transdiagnostic, because they specifically wrote transdiagnostic in the title. And then we've done a semantic analysis. We found that most of them were investigating depressive disorders, as well as bipolar and other mental disorders. And then we tried to look into more depth at how these articles, scientific articles published in the last 20 years, they have operationalized the notion transdiagnostic. And what we found was that some of them, they said, we are transdiagnostic because we study mental disorders and physical disorders. So this is the transdiagnostic definition. One of the speakers is a neurologist, and I was chatting with her, and she's very interested in this area. And then we will hear about that, about the overlap between somatic medicine and psychiatry. This is one way of defining a transdiagnostic approach. Some of the studies were not transdiagnostic at all. So they report in the title being transdiagnostic, but eventually they did not even take care of formulate any diagnosis at all. They said, we have not used ICD, we have not used DSM, we have not diagnosed at all, but we are transdiagnostic, which seems a bit tautological. Some of the studies, they said we are transdiagnostic because we are measuring, for example, psychotic and depressive symptoms, confusing symptoms with diagnosis. And some of the current transdiagnostic studies, they claim to be transdiagnostic within the same diagnosis. For example, because they say we are studying the prodromal psychosis and the first episode of psychosis, so we are transdiagnostic in a kind of clinical staging model. And ironically enough, there are also, trust me, there are also studies claiming to be adiagnostic. Transdiagnostic studies saying we are adiagnostics and therefore we are diagnostics, transdiagnostics. And this is certainly a sort of source of major confusion, which is not helping research, and we need somehow to improve the way we use these words and the way we agree on the terms, the way we operationalize the transdiagnostic construct. For example, we suggested using the so-called Transd recommendation. They are kind of reporting recommendation. For example, suggesting, okay, if you want to conduct a transdiagnostic study across psychosis and depression, maybe report the psychotic and depression diagnosis, how we have formalized them, operationalized them, and then report the proportion of agreement and disagreements in a certain neurobiological phenotype. Otherwise, it's difficult to understand to what degree the study is truly transdiagnostic. There is also, and I think, another conceptual limitation. How novel is the transdiagnostic approach? So if you look at DSM-4, there was a statement which then has disappeared somehow, and the statement in DSM-4 in the first pages was saying there is no assumption that each category of mental disorder is a completely discrete entity with absolute boundaries dividing it from other mental disorders. And to me, this sounds kind of suggesting that already the DSM-4 was already opening the door to a possible transdiagnostic endophenotype and approach. So it's always something which has been there in the air. The major limitation to me which builds up on what I've been discussing so far, is that if we are not clear in the way we operationalize the transdiagnostic approach, we may also risk inflating the findings. For example, as highlighted by some colleagues like Professor Parnas, there is a risk that transdiagnostic approach is somehow a result of form of trivialization of psychopathology. What do I mean? Okay, so let's just take, you want to measure psychosis, we want to measure psychotic symptoms. Then my question is, what makes a psychotic symptom psychotic? How can we define a psychotic symptoms, measure it across different diagnoses, and then ensure that what we measure is truly transdiagnostic? For example, we can use self-reported assessment instruments like the CAPE. Don't have anything against the CAPE, but in the CAPE, for example, there is one question such as, do you ever feel as if some people are not what they seem to be? We posed this question to a young teenager who was watching TV and eating cheeseburger, and he's answering yes. We pick up the question and then we do the same in another adolescent. At the end, we conclude that actually, yes, psychotic symptoms are transdiagnostic because they are diluted and distributed in the general population across different phenotypes. But these are not symptoms. We are basically interpreting psychopathology like apples on the trees, just without elaborating the gestaltic context and the true complexity which surrounds what we see in the clinic. And then we go back to what Kraepelin and Pinel were observing when they were living with their patients. They were not sending questionnaires. They were spending most of their time with them and therefore interpreting psychopathology in a kind of broader context. So there is somehow the risk that the more we blur our ability to look into psychopathology, the more we find a transdiagnostic phenotype. And this is why, in conclusion, I think that we need diagnosis and we need to be pragmatic. If you want a psychiatry to remain within medicine, we need some diagnostic system. We obviously need to improve our diagnostic system, which is not good. But what are the alternatives? RDoC has been suggested, has been there for many years. Some authors commented it's a road to nowhere. Has it delivered an alternative diagnostic system? No. What about other approaches? Hierarchical dimensional approaches to classification, and again, there have been criticisms that it's not yet ready to be used in our clinic. So the way to go possibly is to refine our current diagnostic system with a transdiagnostic approach, with the view of enriching and improving it rather than trashing something to replace it with a complete different diagnostic system, which is not yet possibly available. We don't even agree on how the term is being used. And this has been suggested by the last editorial and forum published in the World Psychiatry. And I was very impressed by, again, this paper published by our colleague Stefan Leucht this week in JAMA Psychiatry, which basically elaborated along those lines. They concluded saying that ICD and DSM diagnoses can be questioned. And we want to question them because we want to improve them. We have discussed the limitations. We are here today to discuss how to improve them. But psychopathological symptoms and the suffering stemming from them are real and near to nature. This is something we have forgotten, and then it's going back to the first slide and to my final slide. It's something also we try to keep very fresh in our mind, in our clinical practice. And one way of doing that is just to work, to ask patients, what is it like living with problems like psychosis or schizophrenia? If you really want to develop a new transdiagnostic system, this, I think, should be the first starting point, always. And in this co-produced and co-written paper about the lived experience of schizophrenia and psychosis produced with expert by experiences and academics, they told us that, for example, psychosis is one of the most painful and upsetting existential experiences, so apparently alien to our usual patterns of life, at the same time so unspeakably enigmatic and human. Thank you.
Thanks. Thanks, Paolo, very much, and thanks for staying on time. Appreciate it. Paolo, your comments put me in mind of, I guess, an overarching question being reliability and validity, and you spoke to this. The ICD-6, as you know, came out in 1948. The DSM-1 came out in 1952. And the effort was to improve reliability, as you made reference to. And I suppose if I was going to date the onset of the first effort to come up with construct validity of mental disorders, I go back to the famous paper of Robbins and Guzay, 1970, from St. Louis, where they described the 5 aspects to validate a mental disorders: the phenomenology, the course of illness, the family history, laboratory findings, as well as the exclusion of other causes. In other words, a zone of delimitation. So quite frankly, I really see this as a fairly non-controversial issue. We've not really fully validated any mental disorder. That doesn't mean they're not valid. They haven't been fully validated. So it's not as though we're trying to, change the paradigm here in so many ways. The other point is that when we think about other areas of medicine, in fact, as you were speaking, Paolo, I was thinking about the metabolic syndrome of obesity, dyslipidemia, dysglycemia, and hypertension. And they are transdiagnostic. They have their own discrete elements, but there's a point of commonality. And in many ways, that has been an exemplar of a transdiagnostic approach that's facilitated understanding and knowledge. It certainly hasn't reduced the lived experience suffering, and it's also guided therapeutics in ways that have been very much in advance. So thank you for that. Andrea, come on up. Dr. Bartolomis is going to give us a presentation on treating symptoms across mood and thought disorders, taking a transdiagnostic approach. Welcome.
Good afternoon to everyone. Thank you, Professor McIntyre, for the introduction, and thank you, Professor Fusar-Poli, for setting the stage. Thank you so. And also the organizer for inviting me here. I will try to introduce you to the concept of partial agonist, the dopaminergic ones, as transdiagnostic drugs. And to do this, I will navigate with you, we have in time our American Cup, through basically 3 major points. The first one will be why and how dopamine partial agonist can be considered transdiagnostic. Then we will move on the specific mechanism, how this drug works, and how can be translationally implicated in transdiagnostic effect. And finally, we'll try to describe what I believe is the most interesting part of the story, how this drug can affect in divergent way to other antipsychotics on which is considered the basic quantum of brain organization, that is the synapse. So this is my disclosure, and let's start and buckle up with the first question: why and how dopamine partial agonists can be considered transdiagnostic drugs? So this is the present scenario of dopamine partial agonists, which consider basically aripiprazole, the first in the game, the drug that basically changed our concept, how we can treat psychosis. For many years, psychosis and antipsychotics were based on the concept that we should block dopamine, D2 receptor, in order to gain efficacy. Aripiprazole changed completely the game, and from that time we start speaking about no more blockade but occupancy. Then came cariprazine, that by its own characteristics was to be a preferring D3 dopamine partial agonist, the first in the class. And finally came brexpiprazole, that despite coming from the moiety of aripiprazole, is quite different for receptor profile and for some characteristic in modulating the dynamic of dopamine. Now, which are the basic concepts for which these drugs can be considered transdiagnostic? I think we should fit at least 2 hypotheses. The first one, that different psychiatric disorders can share common signaling mechanism that can be partially overlapping, partially divergent. And the second, that this drug should intercept at least one of these mechanisms. Now, if we consider which mechanism, with the reference to dopamine dynamics, I would like you concentrate, please, what should be considered, as already Professor Fusar-Poli was underlining, one of the most and consistently replicated finding in psychosis, and specifically in schizophrenia, that is the increase in striatum of dopamine in schizophrenia patients compared with normal controls as measured by raclopride displacement with PET scan after amphetamine challenge. This is a replicated finding in several different contexts, different naive patients that were under treatment with antipsychotics, has been consistently demonstrated with one exception. The exception is represented by the patients that are not responsive to antipsychotic, that we call treatment-resistant patients. On the other side, there is a different way in which we can do these experiments to measure the capacity to uptake dopamine in striatum. This can be done by fluordopa. And with this technique and the previous one has been shown quite clearly that it's not only true in schizophrenia, but can be applied also to other non-schizophrenia psychotic disorder as well as delusional disorders. Therefore, there is a kind of transdiagnostic mechanism that can be applied in this situation. But what's most interesting is the fact that despite the transdiagnostic, we have for the dopamine dynamics, an intradiagnostic difference. Why? Because there is no just one direction release, increase or hyperdopaminergia, but considering the different brain region, a different status of the disease, we can have just the opposite one. For example, we can have a decrease of dopamine, as been demonstrated again with the same technique by measuring dopamine in prefrontal cortex, also in dynamic conditions such as the sorting test. So we have two different situations. It makes sense that we should have drugs that are sensitive to differential condition of dopaminergic dynamics and can adapt to this condition. Now, how molecular signature of partial agonists may translate in transdiagnostic clinical efficacy. Here it's a paramount diagram that shows the difference in receptor profile, but what I would like you to consider is the fact that all these drugs, despite being denominated partial agonists, they are also considered what we call bias ligand, or if you prefer, functional selective drugs. That means what? It means that not only they are partial agonists to dopamine receptor, but they also can adapt to the signaling functional selectivity according to the neural type and the signal mechanism that is after the interaction of the receptor. Typical one is the CMP cyclic mechanism of the beta-2 arrestin mechanism. So one thing that makes sense is to show that these drugs, despite belonging to the same class, they have some differences. In case of aripiprazole and brexpiprazole, the major difference is with brexpiprazole that being more on the side of antagonist action. As you know, which characteristic of this drug is to have all a medium high, depends the drug, what we call intrinsic action. That means what happened after the interaction with the receptor. And usually it's measured as the capacity of the drug to reduce the accumulation of CMP cyclic under phosphocholine induction in a dopaminergic clone cell. In case of cariprazine, it's quite clear that this is the first drug that's been shown to have much higher affinity for D3 receptor, one magnitude compared to D2, that means 10 times higher. And this is interesting because in the last year there is a lot of interest for dopamine D3 receptor that is considered a very specific target for new development of small molecules very recently been discovered that this receptor has a pocket that can be addressed for targeting and for new drug discovery that allows probably to avoid, which is a common phenomenon of dopaminergic receptor, is go from low to high affinity and therefore loss efficacy from the drug that should address the receptor. It seems, in other words, that D3 dopamine receptor are much less compelling to the high affinity, and therefore it's much easier that the efficacious effect can last over time. Now, it's also interesting, just remember that cariprazine is basically 3 drugs in one, and that the 2 major metabolites that are desmethylcariprazine and D-methylcariprazine may have a little higher affinity to D3 compared with the mother drug. Now, all this about D3, how can translate in human living brain? There is a quite now acceptance that this is true also in human living brain, as measured by PET scan and the use of H3PO radioligand that show clearly that this drug can separate the interaction with D2 and D3 receptor, being affected the D2 of 40% and the D3 almost 70%. But what is more interesting, that this peculiarity at D3 receptor has also a translational effect, because it has been shown that cariprazine and other D3 selective drug can interact much faster with the D3 receptor, and this is an interesting, I would say also epistemological interest, because has probably to do also with the capacity to modulate very quickly the dopaminergic system. And this is particularly for one aspect, that is the sense of time. We forget about this, but we should remember that dopamine is absolutely substantial for the dopaminergic regulation of the time. That is something that compromises in many psychiatric patients. Now, this is true for psychosis. What about other psychiatric disorder? We be aware the fact that we should not translate in very pindaric way, but we should be very careful that what happened in animals and what happened in vitro system not can be considered always true for human being. But there are some interesting paths that we should consider. First of all, change in dopamine tuning have been demonstrated, for example, in major depression. And what is interesting that if we induce depression in animal with all the limitation of animal model, we are able to modify D3 expression. Very recent with a new technique that coupled both radioligand as well as antibody technology has been shown that one of the major side of the effect in depression model in animal is represented by the D3 tuning in a region that's been for a long time considered crucial in the limbic system, but has not well characterized till now. That is the island of Carlegia, that are essential in modulating dopaminergic system in the limbic pathways. Now, it's also true that beyond dopamine dynamics in major depression, there is also a strong effect of change in dopaminergic dynamics in mood disorders. In some way, here the situation is mechanicistic different, because it's believed that the increase of dopamine in mania is not related to increase in release, but is related to malfunction of dopamine transporter. So dopamine does not go back inside the synapse, it stands in synaptic space. And this is related probably to the fact that the dopamine transporter, at least in some patients, has been demonstrated, does not stand on the surface of the neuron, but inside the cell, and therefore cannot act as a transporter. Now, again, several partial dopamine agonists have been shown to be effective in animal model. Brexpiprazole is one of this, and cariprazine too, both at the singular level of cell as well at behavioral level. Moreover, it has also been shown that cariprazine can mimic some effects of lithium in a discrete animal model and cellular system. Now, we know that this probably has to do also with the large effect of these drugs, not just only on dopamine, but also on other neurotransmitter systems, mainly the noradrenergic one. We always forget that these systems are highly interconnected. There is not just a dopaminergic one and the noradrenergic one that they just separate, but they are highly interactive. So therefore, we believe that one of the stories to do also with the modulation from dopamine system to the other. By the way, I just want to remember that D3 receptor can form heteroreceptor with other dopaminergic receptor, as well as very recently demonstrated with, for example, cholinergic receptor. And so we have dimers, and dimers act differently from the single receptor. Now, one thing that we just show every time in our system is that patients do not just have schizophrenia or mania or major depression, but they can be patients that are addicted to several drug of abuse, mainly cocaine. We have several animal models, and again, probably dopamine partial agonist seems to be the ones that are more realistic in terms of modulating dopaminergic system, especially because in patients with abuse of drug that increase dopamine tone, such as cocaine, you don't want to just block and therefore reset completely the system. This has probably to do with the fact that dopaminergic drugs may act as a chaperones of D2 receptor. This has been demonstrated for aripiprazole and for, also we should remember, for clozapine. That means that they are able to trap inside the cell the dopamine D2 receptor, avoiding the dopamine D2 receptor goes on the surface of the cell, and therefore cannot be stimulated. This chaperones story is becoming quite interesting because now there are several companies that are interested in try to consider this mechanism as adjuvant to the usual block or agonist, partial agonist at the D2 receptor. One thing that, again, we always have been facing in transdiagnostically in different disorders, from major depression to schizophrenia, going to from bipolar disorder, is the cognitive deficit in patients. Very recently, Professor McIntyre has been shown that cariprazine may have some pro-cognitive effect in different and transdiagnostic conditions. In what we know that if we block with NMDA receptor, what is the dynamic of gamma oscillation? Gamma oscillation are oscillations in the brain that are major organization for the topography of the brain, functionally speaking, and are oscillation between 30 and 90 megahertz. When we block NMDA receptor, that is one of the mechanisms considered the pivotal for dopaminergic dysfunction, at least in psychosis, we can alter the gamma oscillation. And what will happen, the gamma oscillation become much higher in amplitude. But then if we treat the system with a partial dopamine agonist, we reduce and counterbalance this effect. The same thing has been shown also for another condition that's related to gamma oscillation. It is novel object recognition that is altered by NMDA blocking agents such as ketamine, such as PCP, but can be reversed by partial dopamine agonists. I will just remind you that this can be probably a proxy with all the limitation of animal model for which we consider negative symptoms in humans. And as you know, cariprazine has been shown to be superior to antagonists at D2 receptor in patients with prevalent negative symptoms, not just all negative symptoms. Now, last part, how these drugs may affect the basic structure of brain organization, the synapse. And as you know, probably there is one structure that's known as a postsynaptic density that is considered the major organizer, the hub of the dendritic spine, and has been shown over the time to be basically constituted by receptor, adapter, scaffolding protein that make the architecture of the dendritic spine. Now, this structure and the molecules that are inside this structure are highly associated with several psychiatric disorders transdiagnostically, such as schizophrenia, major depression, and bipolar disorder. But what's more interesting that this structure is highly affected by antipsychotic treatment. And I will show you specifically what happened with the drug that you use every day when we treat rats on the dendritic spine, and specifically on one of these genes that has this extraordinary name, Homer, from Homer Simpson, that I will show you what's going on. This is the expression of the gene. You see the autoradiograms on the left, on the right you see the diagram that reconstruct the basically expression of the gene. Now, this is what happened when we treat animal with alloperidol. There is a blowing of gene expression into striatum. It is matched probably the fact that this drug acts mainly on the D2 receptor in striatum and responsible of extrapyramidal symptoms. Then this is what happened when we treat the animal with the clozapine. That means much lower action on the striatum, and this fits again with the fact that the clozapine not only does not give EPS, but even can be beneficial in some motor disorders such as tardive dyskinesia. And look at this, what happened with aripiprazole. This is something very interesting, because usually we have been detected an increased dose response. The more we give of drug, the more we activate this gene in the brain. In the case of aripiprazole, is not like this. The higher concentration, the higher dosage gives lower activation. That is absolutely consistent with the fact that these drugs do not block dopamine receptor, but they can tune dopaminergic system through the dopaminergic partial agonism action. So let's go for the final remarks, and just I will show you one thing that I would really like you to consider. We're speaking today about the transdiagnostic drug in psychiatry. This is absolutely important, but let's be clear. This is something that's already been captured by the rest of the medicine. I have one case for all. Probably you know that back in 2019 there was a revolution in oncology by the introduction of the new molecular and what we call molecular antibody of third generation. They do not address the cancer directly, but address the lymphocytic system to then attack the cancer. And this was at the beginning done only for one kind of cancer, that was skin cancer, melanoma. Now it's used for at least 4 different kinds of cancer with completely different mechanisms, but they share one common signaling, that the CTL4 break on the lymphocyte type, and therefore we can really believe that we should stop thinking about very strict diagnostic system and think about pathological mechanism can underlie the efficacy of the drug we use to combat this disorder. Thanks.
Step here.
You go.
That was impressive in scholarship, impressive in delivery, and also impressive how you got Homer Simpson in the presentation. Congratulations. A wonderful example that you gave at the end. I agree with you. You know, as you were describing the role of D3 and its transdiagnostic mechanistic role, in addition to making me think about the appetite for mechanistically informed therapeutics in psychiatry, I had a different example come to mind. Not mutually exclusive. And it's the glucagon-like peptide 1 receptor agonists. And when they were discovered, it was soon determined that they affect glucose stimulation on the insulin system in the beta cells of the pancreas. They became indicated in type 2 diabetes, then indicated in obesity, then cardiovascular disease. And now it's expanding into fatty liver, or what we now call MSILD, maybe other conditions as well as in psychiatry. Parkinson's disease, Alzheimer's disease, reward. So there's a lot of parallel between what you described in D3 and what we see in other areas. I agree, especially the GLP-1 system with tremendous public health implications. Great job. Maria, come on up and join me if you could. The next presentation is Treating Symptoms Across Mood and Thought Disorders, Transdiagnostic, Applying the Transdiagnostic Approach in Clinical Practice. Welcome.
Thank you for the introduction. It's my real pleasure to be here, one of the speakers of this excellent symposium. Thank you for having me here today. You know, I am not only a neurologist and psychiatrist, but also a clinical geneticist, so I will start my presentation with some genetic aspects. This is my disclosure. So I think we know very well that many psychiatric disorders have shared genetic backgrounds. Just looking at the schizophrenia, the genetic risk factors for schizophrenia are also genetic risk factors for bipolar disorders, major depressive disorders, OCD, autism spectrum disorders, and so on. So these shared genetic risk factors are bringing us shared biological pathways, and that's why we have the conclusion that maybe one particular drug might be effective in more than one indication. So schizophrenia is well-known dopamine-associated disease, but we have other disorders which are dopamine-associated, and these have numerous clinical manifestations. And these are related to different dopamine pathways. Just have a look. Here is the mesocortical pathways. It is related to negative symptoms, cognitive impairment, and depression. The mesolimbic pathways, if they are altered, they are related to negative symptoms. And we have the nigrostriatal pathways, and there is two different parts. One is the associative striatum, and it is related to psychosis. And if we have some alteration in the nigrostriatal pathways sensory motor part, we have motor symptoms. These are very well known, like dyskinesia, akinesia, rigidity, tremor, and dyskinesia. So despite the fact that dopaminergic dysfunction contributes to the development of both psychiatric and motor symptoms, these symptoms classes are separated. So if we have predominantly motor symptoms, it's a neurological condition. And if we have predominantly non-motor symptoms, we call the disease as a psychiatric condition. However, in most of the cases, besides the motor symptoms, non-motor symptoms can be present as well. We know very well that nowadays many research projects are focusing on the overlapping symptoms between neurological and psychiatric disorders. And these are looking beyond the traditional disease classification. Look, why is it? We have the upper dimension. It is the biological dimension. We know that we have some monogenic disorders. We have some disorders where we have different polygenic risk factors. These are affected by the environment, and what is the end result? That we have different gene expressions in the brain, and these will result in brain circuit dysregulation. And what is the end result? On the symptom level. On the symptom level, we have positive symptoms, negative symptoms, motor symptoms, and so on. And then we are arriving to the disease classification. And you can see that how did we classify these disorders? Some of them are classified based on the describer who described the first time the disease, for example, Parkinson's disease or Huntington's disease. In others, the presenting symptoms are very important in the classification, for example, major depression disorders or obsessive compulsive disorders. And we have some, for example, mitochondrial disorders, which has something to do with the biological process as well. So these symptoms emerge independently of whether the disease is a neurological or psychiatric condition, proposing a symptomatic overlap between neurological and psychiatric disorder. And for me, this is the transdiagnostic approach. In my presentation, I will focus on 3 symptoms: affective, negative, and cognitive. And if you look at the slide, you will see different psychiatric conditions in which these three symptoms are present. But there are also neurological conditions, such as Parkinson's disease, Huntington's disease, and even Alzheimer's dementia. So, what are the main key players in some aspects of these symptoms? The different dopamine receptors. And since we have the partial agonists, we know that maybe balancing these dopamine levels may improve the clinical symptoms. So this type of partial agonist that we have heard today, cariprazine, we know that cariprazine is approved in Europe in schizophrenia, and 6 different randomized clinical trials approved the efficacy of cariprazine in this disease. And in the US, it's approved in other indications as well, for example, as an ADA therapy in major depressive disorders. And you can see that there were 5 different randomized clinical trials which proved the efficacy. But we have also further clinical trials in bipolar disorders, which could approve the benefit of cariprazine. There is a difference between the depressive and the maniac episode. In the depressive episode, lower dose, 1.5 and 3 milligram per day was efficacious, and in the manic episode, a higher dose between 3 and 6 milligram per day had a good benefit. If you are looking in the literature, you will find case reports where they are reporting about the efficacy of cariprazine in other different conditions. Just look at this list. Some of the disorders are psychiatric conditions, some of the disorders are neurological conditions. Do we have something shared biological pathway between them? Maybe. Basal ganglia can be very important, and dopamine can be also very important. If we are searching the shared biological background of these disorders. We performed a systematic search for case reports where cariprazine was used with a good efficacy, and we identified 38 different case reports. You can see that most of the indications were psychiatric indications, but we had also some neurological conditions as well. And what was the reason of cariprazine administration? In most of the cases, the lack of efficacy of the previous treatment, so they were not responders. And if you look, most of them had negative symptoms, positive symptoms, cognitive problems, and affective symptoms, and even psychosocial functioning. And in some cases, there was intolerable side effects, for example, weight gain, psychomotor retardation, agitation, or insomnia. What are the efficacy outcomes in these case reports? In most of the cases, both positive, negative, and cognitive symptoms improved, and also the affective symptoms. And in the substance abuse cases, in all relevant cases, the symptoms completely ceased. It's also very important that in these case reports we could read also about the improvement of the psychosocial functioning. What about the safety outcomes? Cariprazine improved several safety aspects, for example, sleep disturbances, weight gain, and sexual dysfunction. But we have seen akathisia in several patients, and it was the cause of the discontinuation in 3 cases in these case reports. And from now, in the last part of my presentation, I would like to share with you my own experience. We are focusing on mitochondrial disorders, and I would like to present a case to you. This guy had a MECP2 mutation. It's very well known that MECP2 is associated to Rett syndrome, but usually who are ill, it's a female disease, Rett syndrome. But we have a male. It is increasing the number of the males who have psychiatric problems associated with MESIP2. And it's now well known that it's a mitochondrial disease. MESIP2 is a nuclear mitochondrial gene. So our patient had a delayed speech development. He started to speak at age 3, but after 3, he was a talkative small child, and the problem started at age 10. After 10, he started to be speechless. And later on, anxiety came. At age 17, he was diagnosed with anxiety and depression. And he came us at age 34. At that time, he had very severe negative symptoms, alogia, avolition, apathy, very severe anxiety, and also cognitive deterioration. And he had also some somatic complaints, especially exercise intolerance. That's why we started to diagnose him as a somatic disease, and as it turned out that it is a MESIP2 mutation, but we have to treat him, and we started with cariprazine because of the negative symptoms. And you can see on these graphs that especially the negative symptoms, the cognitive symptoms, and also the affective symptoms were improving. We had to increase the dose of the cariprazine because at the beginning he was only a partial responder. We had to add some benzodiazepines, and since over the dose 3 milligram per day, he had also some akathisia, so procyclidine was added on as well. And so we were so lucky that after 8 months, he was able to go back to have a rehabilitation work. So the social withdrawal was improved also a lot. The other disease group, what I would like to present you, Huntington's disease. It's a very well-known dopamine-associated disease, but it's a complex. Not only dopamine is the most important key player, and it's a neurodegenerative disease. We know very well that there is a dopamine imbalance in the striatum and in the prefrontal cortex. And it is also well known that in the pre-symptomatic stage, we have very high dopamine level, and this high dopamine level in the later stage will decrease. And what is happening with the dopamine receptors? They will decrease. Both low and high dopamine level can lead to behavior, mood, and cognitive dysfunction. But since we know that we can stabilize the D2 and at the dopamine level, acting with partial agonists on the D2 and D3 receptors, it was our hypothesis, why not to try to treat these patients with cariprazine? Because you know, these psychiatric symptoms, especially negative symptoms and affective symptoms, starts several years before the motor symptoms. And you have to treat your patients before the motor symptoms. So we had 15 patients. It was a retrospective study, and we were following our patients. We followed the behavior symptoms, the depressive symptoms, cognitive symptoms, and the motor symptoms as well. We started with low dose, 1.5 milligram per day, but in some cases we had to increase the dose. And of course we were looking for also the safety parameters as well. And what are the results? It was very efficacious, both in the regarding behavior symptoms, cognitive symptoms. You can see that UHDRS behavior examination scale showed after 12 weeks significant improvement, and cognitive symptoms measuring Addenbrooke cognitive examination and cognitive assessment of the UHDRS had also very brilliant significant improvement. The mood symptoms were also significantly improved, but not so well as the other two. And surprisingly, motor symptoms improved as well. Let's see the individual data. On these graphs, I can show you the individual impairment. So the UHD rest behavior assessment could identify in 14 cases among the 15 improvement, and it was significant. The Addenbrooke cognitive examination showed a very similar 14 cases improved and only one was not very well responding. The back depression inventory scale was not the same. In this case, only 11 patients improved and 4 patients was showing not the same improvement as the other ones. And on my last slide, I can show you the motor symptoms. Only one patient did not show improvement during the cariprazine treatment. All the others had a very nice improvement after the cariprazine treatment. So my final conclusion is transdiagnostic approach, which captures the overlap between psychiatric and neurological disorders, represent a novel way of conceptualizing underlying mechanisms that contribute to mental health, moving beyond the traditional classification. Many psychiatric and neurological disorders share common genetic and pathophysiological features, suggesting a significant overlap in their origin. And as a result, is a high likelihood that shared therapeutic solutions could be beneficial for these disorders. And based on the results of the clinical trials and the real-world data, we can suggest that dopamine partial agonists such as cariprazine may be safe and effective in treating a broad range of symptoms associated with various dopamine-related disorders, regardless whether these conditions are classified either psychiatric or neurological. Thank you very much for your kind attention.
That was wonderful. Thank you very much. And just to pick up on your final point, which I'm glad you reiterated for us to keep the focus very sharp, that the theme that emanates and surrounds your presentation is the theme that we have a opportunity to target a molecular system that is relevant across disparate dimensions of psychopathology. So the message is not that a treatment like cariprazine is able to treat an endless number of mental disorders. That's not the message. The message is it's treating underlying biology that is common across a finite number of dimensions. And to borrow from the work of the RDoC, in the language of RDoC, positive valence disturbances like mood and negative symptoms, negative valence around irritability, hostility, agitation, and then the general cognitive systems. That point's well taken. You know what's remarkable as I reflect on our symposium so far, we've been together for just over an hour, and no one's used the word comorbidity once. And we got a pandemic of comorbidity in psychiatry. I've always been curious, when I see patients with major depression and bipolar, that's been my career for most of the last 30 years. And everyone here hears patients when they come to their office in the 20s, in their, say, mid-20s, a patient will say, well, when I was at age 6, I had ADHD. And when I was 12, I had anxiety. And when I was 15, I used illicit drugs and alcohol. And then when I was 20, I started having problems with panic. And then I had depression at 22, and I had mania at age 24. So is that actually 5 different psychiatric diagnoses? I don't think so. It's probably an example of what we call heterotypic continuity, where you have a common neurobiology that's changing its phenotypic manifestations across time, but within a finite repertoire of psychopathologic dimensions. So I really enjoyed your presentation, so thank you very much. Okay, so I'm going to just quickly go through if I can. And by the way, thanks for submitting your questions. They're coming through on the Slido, and we're going to have some time for some rapid fire. Rapid fire. I'm going to ask my colleagues to keep the answers short. We'll get through as many as we can on the questions. And so really, as I see the key session points is that we in fact have before us, whether we embrace the DSM or the ICD or whether we step backwards a little, say 5 or 6 steps, and we consider biobehavioral matrices like the RDoC, our effort has always been similar for decades. That is to make a diagnosis in a way that's reliable, but also to, in fact, validate our disorders. And what we know from clinical experience, what's very clear in these very detailed symptom structure analysis that you've been hearing about, is that going back to Robbins and Gouze of 1970, their great paper from Washington U, we still don't have a zone of delimitation, discrete boundary between these disorders phenomenologically or neurobiologically, and that has provided the basis to hypothesize that if we can identify a common substrate, and more specifically a druggable substrate, then maybe in fact that could have transdiagnostic application. And I see the D3 identification in the work we've seen so far, I think a wonderful proof of the concept that if you can identify and engage a target that's mechanistically so critical across the dimensions of so many disorders, then you're going to have a broader spectrum application. That's a near-term summary of what we heard so far. But as we look to the future, the next 5 to 10 years, again, the regulators have to be on board with this, and that's a separate but related discussion, is the therapeutics that we now have seen, the introduction of the orexin antagonists, the NMDA antagonists like esketamine, ketamine, the GABAergic agents, brexanolone, zuranolone, and now moving towards the selective kappa opioids, drugs that include KCNQ and so on and so on. The field of psychiatry, the zeitgeist is changing towards a more mechanistically informed way of developing pharmacologic treatments for people with lived experience. And in many ways, cariprazine as the D3 engaging drug serves as a, in many ways, paradigmatic of how we should be thinking about drugs in the future. Very quickly, I want to introduce a scale, the Transdiagnostic scale, the TGI P scale. This has been recently published. I'll keep it brief. At the end of the day, what we want is measurement-based care at point of care in clinical practice. You've been hearing about transdiagnostic phenomenology, convergent neurobiology, and possibly common therapeutic. But we walk into the clinic, we want a way to assess, to track, to visualize symptoms. And measurement-based care has been variably embraced, despite the fact that the evidence is unequivocal that the effect size advantage of implementing measurement-based care is similar to prescribing an antidepressant. In other words, a clinically meaningful effect size. And the question is, if we're going to be speaking about transdiagnostics, is there a scale for that? Is there an instrument for that? We know we have instruments for depression and anxiety and ADHD and so on. So that appetite provided the impetus for the genesis and the preliminarily development, now moving to full-out validation of the TGI scale. Now, for those of you who are saying, this sounds a bit familiar, don't we have a CGI scale? We do. We have the CGI scale, which was introduced into psychiatry in 1976. That was a remarkable year in psychiatry. It was also the year that David Dunner introduced bipolar II disorder, and Caitlyn Jenner won the gold medal in Montreal that year. It was quite a year. Anyhow, CGI was introduced by the NIMH in 1976, and we know it to be a scale that has broad application. There's also more disorder-specific CGI scales like bipolar and schizophrenia. And this is a very simple, I've always liked the CGI scale as a severity metric cross-sectionally ranging from 1 to 7 along a Likert scale. And so rather than reinvent the wheel, we thought, why don't we borrow from the wheel? And this is the CGI template. You see these concentric circles, the inner circle being 1, which means otherwise well, 7 being the most severe presentation of psychopathology. And then through an iterative process, this was in part done just by socializing with colleagues, but also looking to the literature, there was an effort to identify dimensions or domains, symptom domains. And this is an iterative activity, which means it's sort of back and forth, and there's an element of criterion validity and face validity you're trying to look for here. And what was arrived at was 10 different dimensions. No matter what area of psychiatry you work in, if you look at any disorder in psychiatry, ranging from pediatrics to geriatrics, every mental disorder has a constellation of symptoms that can be identified on this particular 10-item checklist. And some people like things presented in table form, some people like things in digital, some people like visual. There was a decision to make this a visual instrument for easy assessment. And these 10 items are presented in this very interesting looking diagram. And these 10 items are, in some cases, could be hyper. In other words, you can't be under psychotic, but you can be psychotic. So that can only be a positive dimension as one example. So some of these dimensions don't lend themselves to hypo, they lend themselves only to hyper. And other dimensions lend themselves more to hypo. You can see here, like for example, typically people who are living with mental illness don't have improved cognition, it's decreased cognition. And then a couple of these items actually had either increase or decrease. And the idea here was in fact to provide a quick way to assess, track, and visualize transdiagnostic psychopathology. Here's an example. This is an example of an adult with bipolar disorder in a manic episode. Look at the manic symptoms at about 8 p.m. If I use the clock metaphor, you got full-blown mania, and you can see as evidenced by a 6. Let's go down to the 6 p.m. on that slide. See sleep at 6? Well, that's also quite impaired, as you might expect in bipolar mania. In this case, this bipolar manic patient has depression at about 1 or 2. Some patients that's true, some it's higher, and so on. So it's a very quick way to look at this. This is an acute schizophrenia. This individual would have if you look at 11 p.m. on the slide, you see this person has positive symptoms. Let's read counterclockwise. Hostility item, keep going. They have addiction symptoms, and so on, and keep going around the clock. Now at about 5 p.m., you can see negative symptoms. And it's also possibly a way to track symptom progress or lack thereof across time. And in fact, in this case, as an exemplar, an acute phase presentation visually, followed by remission, followed by recovery. And this is an instrument that is now moving to full-out validation, looking for sensitivity to change, which is going to be critical. And there's also related CGIs that are being considered and going to be future validated, that being a CGI patient version and also a CGI informant version. So we need items, we need measurement-based care, helps us objectify symptoms, it helps us to detect, it improves the focus, sharpens the focus, it allows the clinician to select and sequence treatments that are targeted. It's also evaluated by lived experiences very positively. That sounds all pretty good to me. And the CGI was used as a template to, in fact, now create this new Transdiagnostic Global Impression Scale. You can download it. It's free. It's open access on its publication. You can see other ways to access it, including this QR code. But you can also go next door to the Gideon Richter booth. They'll pass it out to you. So it's freely available, and that's a pretty good price. So with that, what I want to do now is take the remaining time and go through some questions, possibly answers. We don't always have the answers. So it's a Q session, maybe an A. So let's go. Maybe, Paulo, for you first. Computational psychiatry. I'm going to edit this a little bit. I think what our colleague, is asking about is language models, AI. Does that have an application in transdiagnostic psychiatry?
Thank you for the very easy question. There's a future, certainly. That's where we are looking at, and I think we all need to be very open to innovation, psychiatry, and technology. And sometimes it's just a new way of rediscovering old problems. Language has always played an important role in psychopathological assessment in psychiatry. Now we are trying to automatize that, to detect that, improve the prediction of future trajectory by using AI models, which needs to be validated, but they can indeed be very, very, very powerful. In my field, in my clinic, for example, we are using AI for digital screening of the community, analyzing spontaneous speech to try to detect early psychosis. So I think this is all promising. Still, we need more research, more validation to bring these tools in clinical practice.
Let's follow up with a question on mitochondrial diseases. And it's a transdiagnostic question, so very appropriate. What is the evidence supporting energy or bioenergetic dysregulation in schizophrenia or other disorders like bipolar and major depression?
So I think there are so many publications about it that even in schizophrenia and in autism spectrum disease, mitochondria have many things to do. You can find also some genes. As far as I know, 3 genes are very strongly associated. For example, this one is very well known schizophrenia risk factor, and it's a nuclear mitochondrial gene. And I think I was talking about the dopamine, and the mitochondria have a very important role also in the dopamine synthesis, in the neurotransmitter synthesis. So I think it's a very, very complex question, and we see so many mitochondrial patients. It's a multi-systematic disease, so we have problems in different organs, but the psychiatrical involvement is very, very frequent.
It's a very interesting question. I agree with you, and I've been especially interested in this question myself. And what's additionally interesting is that we're guilty of neck up. We didn't say much about the neck down today. And we know that the dopamine receptors are also located in the pancreas.
Yeah.
And more specifically, the D3 receptors are located on the beta cells.
Yeah.
What's their role? Well, they're involved in Jesus, glucose-stimulated insulin secretion. So isn't it interesting that D3 is located in the islets of Calleja, which sounds like a wonderful resort, by the way, the islets of Calleja with reward. You also described how D3 through the soma, the autoreceptor, projects up to the cortex, affecting glutamate and dopamine signaling. But also D3 is in the pancreas. Yes. It's an interesting evolutionary model, how reward, cognition, and energy availability are so inextricably intertwined. Love the question. Over to yourself. Question. One of our colleagues is asking about other therapeutics in the antipsychotic class. One of the examples is amisulpride. Is what we're talking about only confined to cariprazine, or would this concept extend to other antipsychotics or other psychotropic drugs?
Yeah, basically, this is a wide concept for therapeutics that target dopamine receptors. However, we should be quite careful about the extension of the concept in which we consider how this drug works. I just want to make a clear point. Dopaminergic system is not there just for the pathophysiology of schizophrenia or for mania or for bipolar disorder. Dopaminergic system is an old, very conservative, a well-kept phylogenetic system that is there for completely different reason, and therefore each time we use drug, the target system, we should remember that we do not do only a therapeutic effect, but we also modify, which is the physiology of one major mechanistic system that full drive the brain. So therefore, going back antipsychotics, I believe that many action of partial agonists can be also captured in other antipsychotics. But we should be very careful to try to understand if this mechanism can then be translated in therapeutics. Just can give one example. One of the major partial agonism that is not related to dopamine, it's related to serotonergic system, is inside a molecule that everyone knows it's an old molecule, probably the most efficacious drug that we have in psychosis is clozapine. Clozapine has a moiety that is a clear partial agonist at 5-HT1A receptor. So therefore, I want to be quite clear about this. We have a completely different, innovative class of drugs, but if we look for each specific mechanism, we probably can capture some kind of specific signal in different kind of antipsychotics.
There's a question here that I'm going to read out loud, but before I do, I'm going to preface with a couple of comments. The most studied intervention in psychiatry is placebo. Secondly, we know that amongst effective therapeutics, such as antidepressants, the placebo effect represents 75% of the effect. In drug discovery and development, in device discovery and development, placebo response has been very high and in some cases increasing, which makes it difficult to detect the signal. And our colleagues asking, why did brexpiprazole fail in the treatment of bipolar mania? There were trials done with brexpiprazole where it did not beat placebo. Yes. Well, I'm going to actually provide my own opinion, and I think it's because of a placebo effect. I think it's an expectancy effect. And that's been a major issue. Now, coming back to the topic we're focusing on, if we can, in fact, be more refined in the mechanism subserving the pathology and target the mechanism in a very targeted way, could that decrease the placebo response? Could that? And that's a testable hypothesis. At the end of the day, we still have to beat placebo. And that's a complex issue. But one wonders whether or not, if we are more targeted, it may actually have a different effect on the placebo response. So brexpiprazole, in my opinion, did not beat placebo in mania because of contextual factors. And so I think it still remains an open question. Okay, we've got a couple more minutes left, and maybe we'll ask this for you all. Okay, this is an open question, whoever wants it. A lot of questions on AI. I mean, people seem to love ChatGPT here today. A lot of people love chat. Okay. Now, with respect to what we're talking about here today, do we have any evidence that psychotherapeutic interventions are transdiagnostic? Anyone want to take that one?
If I can, just quickly, I think the most effective transtherapeutic intervention is the psychiatrist and then the clinical relationships, and that's a quote from Balint. So we all know that, and it's partially also explaining the so-called placebo effect. And there is evidence also testing, for example, talking therapy across different dimensions, and yes, there is evidence that they are maybe effective. And this is indeed what we do in clinical practice, even in early psychosis. We don't just treat early psychosis, we treat the symptoms and the problems the patients themselves present as they appear, whatever the label.
Thank you very much. Any other further comments?
No comments.
Well, as is often the case when we have a topic that is so interesting, this is such a critical topic to the field conceptually and also pragmatically from the discovery and development perspective, but also clinically. The time goes by very, very quickly. I want to mention that for me at least, I think this is going to be a wonderful conversation for the next few years, especially as we have coming online some really interesting new therapeutics that may not only target dimensions of psychopathology, but target aspects that are related to psychopathology, like suicide. Yeah. In suicide, we know we have benefit with esketamine and ketamine, and there's a need to have a therapeutic that can not only target these multi-transdiagnostic dimensions, but also, in fact, target these very important public health aspects. My colleagues have taken their time. They put together succinct, thought through, compelling, comprehensive, and certainly very accessible presentations, so thanks to all three. Thanks to Gideon.